this fall, and we're really excited about it. I can put the link in the chat after I'm finished with my introduction here. But it's worth looking at to see the breadth of activities that our center envelops. And if you haven't already, I'd further encourage you to become a member of the center. I can put that link in the chat too. Membership is free to everyone, those at UW and those in our broader community. And signing up as a member will get you on a mailing list to keep you informed about important center announcements, activities, and educational events. The center's overall mission is to improve palliative care for all people of all ages with serious illness and their family members by integrating research, education, and clinical care. And so this slide shows our current programmatic structure, highlighting areas of recent growth. We have a longstanding focus within the center on clinical education and research operations, and it's the research operations arm of the center that programs this monthly conference. But more recently, we've been focused on developing and integrating programs related to pediatrics, quality improvement, and equity, diversity, and inclusion, which is the perfect connection to today's talk. I'm delighted to introduce our speaker, Dr. Rashmi Sharma. Dr. Sharma is a native of the state of Washington, received her medical training here at the University of Washington, where she completed medical school and her internal medicine residency. She then completed a general internal medicine fellowship at Johns Hopkins University, where she received a master's in health sciences from the Bloomberg School of Public Health. Following fellowship, she was a faculty member in the Division of Hospital Medicine section of Palliative Medicine at Northwestern University in Chicago. We were delighted when she returned to the University of Washington in 2015, where she serves as a faculty member in the Division of General Internal Medicine at the Center for Scholarship in Patient Care and Quality and Safety, and is one of our core leaders with the UW Medicine Cambia Palliative Care Center of Excellence. Dr. Sharma attends on the inpatient palliative care consult service at the UW Medical Center Montlake campus. She's the director of equity, diversity, and inclusion for the Cambia Palliative Care Center of Excellence, and additionally is the co-chair of the American Academy of Hospice and Palliative Medicine's Diversity, Equity, and Inclusion Committee. Her research focuses on improving the quality of care for patients with serious illness through communication-based interventions with a focus on racial and ethnic minority and immigrant populations. And I'm so excited to hear more about her work today. I will turn it over to you, Rashmi.
Thank you so much. Let me just bring up my slides. All right, how does that look? Perfect. Okay, thanks so much, Erin, for that lovely
Rashmi, I'm sorry, it's in presenter mode?
It is, thank you.
Yeah.
See, that's what I wanted to know. Hold on one second. Talk amongst yourselves for a second.
Putting these links in the chat.
How is that?
Perfect.
Okay, thank you so much, Randy. I appreciate it. All right, everyone. So today I'll be talking with you all about how to think about shared decision making and navigating that process while addressing barriers to equitable care for patients with serious illness. And I like to start all of my talks with this land acknowledgement, acknowledging the land that we occupy today as the traditional home of multiple tribal nations. Without them, we would not have access to this working, teaching, and learning environment. So we humbly take the opportunity to thank the original caretakers of this land who are still here. All right, so in terms of the outline for the talk, I'm going to give a very brief overview of health equity, just so that we're all on the same page in terms of that terminology, and then spend also a brief amount of time describing the role of race ethnicity, literacy, and language. So those are the areas that I'm going to focus on at this intersection of shared decision-making. Then I'll define a framework for shared decision-making and then review some of the data that we have on the effect of shared decision-making interventions on health and healthcare equity. And then I'll end with talking about a few strategies that can be used to support shared decision-making, especially when working with some of these vulnerable populations. So I like this slide because in recent times, there's been a lot of use of these terms, diversity, inclusion, and equity. And I think this is a nice way to understand the subtle differences between those three terms. And then it also helps kind of contextualize the equity piece of things, which is where I'm going to spend my time focusing today. So this quote says, diversity by and large is a fish solution. Bringing different types of fish to the tank sure is diverse, but it doesn't create better pond conditions for all the other fish. You need inclusion to hear what specific types of fish need, and then implementing those structural changes, right? Changes to the pond itself should be the focus of equity-based work. And so that's what we're really trying to work towards, right? Thinking about how do we implement the structural piece of things to ensure that everyone has optimal health, or in the case of serious illness, has optimal care in the context of serious illness and at the end of life. This graphic is a commonly used graphic to kind of show our evolution from thinking about equality to thinking about equity. So over the last couple of decades, most of the research focused on identifying disparities, in other words, detecting differences between groups that reflect social, economic, and environmental disadvantage. The idea there was that, oh, if we detect these differences and then we give everyone the same thing, then we should have equal outcomes, right? But as you can see in that picture on the left, if you give each of these three people a box, you don't enable all three people to see over the fence, which is the goal in this case, to see that soccer match that's going on. The person on the left could actually already see over the fence. The person in the middle has been helped some, and the person on the right hasn't been helped at all. So that kind of shifted our thinking to recognizing that the reality is that everyone is not starting at the same place. And thus, people may need different interventions in order to achieve this goal, right? That everybody has equal opportunity to achieve optimal health. So on the right, then you see that the person in the middle actually needed 2 boxes, and the person on the right actually needed a ramp. So that's kind of where we are in our thinking about these issues, this recognition that everybody is not starting at the same place. And why aren't people all starting at the same place as we think about health and healthcare? Well, there are kind of 3 big areas that are driving health inequities. So one are structural inequities. These are structures that organize the distribution of power and resources differently across lines of race, ethnicity, gender, class, sexual orientation, gender expression, etc. Then we have social determinants of health. You can see many of those depicted in this graphic here on the right. And then as clinicians in the healthcare system, we think about healthcare disparities, particularly clinician behavior. That's where we think about things like implicit bias and stereotyping, things like that. And then system level factors. So how is the healthcare system driving people's ability or inability to get equitable care? That's really the area that I focus on in my research, and it's that healthcare system generally that I'm going to be talking about in this talk. And here's a conceptual framework to kind of show how these different barriers translate into inequitable outcomes in the context of serious illness care. So starting on the left, you can see that there are these different types of barriers. There are personal barriers that patients with serious illness and their families face. That includes things like acceptability, particularly when we're talking about serious illness, we're thinking about acceptability, knowledge, attitudes, and beliefs around palliative care and hospice, demographic characteristics like race, ethnicity, culture, language, literacy, religion, preferences, involvement in care, health behaviors. Then we have structural barriers. Those affect people's ability to actually access and receive healthcare. There are also financial barriers that also contribute to that process. And then we have societal barriers. And as we're thinking about equity, we're thinking about things like structural racism or other historical discriminatory practices that affect people's ability to get high quality care. So those are some of the key barriers. Then we get to these healthcare mediators. So these mediators can either help to facilitate equitable or inequitable care. And here we're talking about characteristics of the clinicians that are providing care. So you can think about things like the level of cultural competency, communication skills, medical knowledge, technical skills, implicit bias, stereotyping. And clinicians are also bringing in their own characteristics to the interaction, right? So we have the providers, age, gender, race, ethnicity, culture, religion, their knowledge, attitudes, and beliefs, again, particularly about palliative care and hospice, as we think about the patient population we serve, their specialty. So all of these things, again, can either help patients to receive more equitable care or can serve as barriers. And then as we're thinking about the types of care that patients are receiving in the setting of end of life, we're thinking about palliative care, hospice, receipt of care in the hospital setting, so acute medical care, as well as the intensity of that care and the duration of that care. And then that gets us to our key clinical outcomes, thinking about mortality, quality of life symptom management, as well as the patient and family member experiences. So here we have things like satisfaction with care and what we're really trying to facilitate, which is receipt of goal concordant care for patients. For the purposes of this talk, I'm going to focus on these two areas, so race and ethnicity, as well as language and literacy. So as I mentioned in the overview, I'm going to talk about these areas kind of briefly because I want to set up how we're thinking about these issues in the context of shared decision-making specifically. And frankly, I could give a whole talk about just the role of one of these factors. So hopefully this comes as no surprise to any of you, but the demographics in the US have been changing over the last few decades. And as you can see in this figure, going from 1980 to 2020, the composition in terms of race and ethnicity has evolved. So that dark blue bar represents the white proportion of our US population. And you can see over these last few decades, that proportion has decreased. The pink is our Latinx population, and that has been increasing over these last few decades. That kind of aqua color blue is for the proportion of the population that identifies as Black or African American. You can see that that's increased a little bit and kind of stabilized over these last couple of decades. Purple is the Asian American population that has also been growing quite rapidly in the same way as the Latinx population, as well as those identifying as multi-race. And then we have smaller proportions for those who identify as Native American or Native Hawaiian. And as we look forward to the future, projections are that that trend is going to continue to the point where by 2045, we expect that actually the racial and ethnic minority population together will make up the majority of the US population. And so as we think about the presence of racial and ethnic inequities in care, it's imperative that we develop processes and tools to address these inequities as we think about the larger proportion of population that we're going to be seeing in the healthcare setting coming from these communities and these populations. And as is the case with literature in pretty much every disease population or kind of clinical setting, in the context of serious illness and at the end of life, we also see plenty of evidence of racial and ethnic inequities in care. So compared to whites, racial and ethnic minority patients are more likely to receive intensive, non-curative treatment at the end of life. They're less likely to receive care that is consistent with their values and goals, and they're less likely to enroll in hospice. There are multiple factors that are hypothesized to be driving these differences. Those include the role of patient preferences, distrust, both in the healthcare system as a whole, as well as in individuals, ineffective communication. And I would say that together, distrust and ineffective communication are also likely contributing to the differences that we see in terms of patient preferences. And I think that's an important point to make. Religious coping and a lack of advanced care planning as just, some of the key factors that are contributing to these inequities that we see. Turning to limited health literacy, the US Department of Health and Human Services defines health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services to make appropriate health decisions. There are an estimated 80 million people in the US with limited health literacy. Health literacy is hypothesized to lead to inequitable outcomes through several factors. And in this conceptual framework, you can see kind of three main factors. So limited health literacy affects access and utilization of healthcare. It affects the patient-provider interaction, and it affects the ability of patients to do self-care, particularly when we think about management of chronic diseases like diabetes and asthma and diseases like that. So for those with limited health literacy, because of the effects on these three areas, we see poor quality outcomes, including more hospitalizations, a greater use of emergency room visits, lower rates of preventative screening, poor ability to take medications, to understand instructions to properly take medications. And for older adults, we see poor overall health status as well as higher mortality rates. All right, so turning to this last area I wanted to touch on, which is limited English proficiency. So how do we define limited English proficiency? There are two main ways. One comes from using US Census data. So the US Census Bureau asks people how well do they speak English? And for those who report anything less than very well, they are typically categorized as having limited English proficiency. In the healthcare setting, we ask people about their preferred language. So within UW Medicine, all patients are asked in what language they would like to talk to their healthcare team about their care. And so for anyone who prefers a language other than English, that's another way to identify those with limited English proficiency. In terms of the geographic distribution of this population, you can see in this map, states with a darker blue indicate those with a higher proportion of Medicare and Medicaid beneficiaries with limited English proficiency. And in this chart, you can see that Washington actually ranks number 10 in terms of states with the largest population. I think no surprise that states like California, New York, Texas, Florida rank at the top 4 as having the largest populations. And as we think about the languages that are represented within this community, this is showing you, based on that US Census data definition I mentioned, the proportion of people who report speaking English less than very well. So that's the orange, green, and purple bars for the top 10 most frequently spoken languages in the US. As you start looking towards the bottom of this list, you'll see a higher and higher proportion of people with limited English proficiency, to the point where for Korean, Chinese, and Vietnamese, you actually see greater than 50% of the population with limited English proficiency. And for my last slide on the LEP piece, here's data for the state of Washington from 2013. We have more than 500,000 people in the state of Washington who report having limited English proficiency. Almost half of that population is Spanish speaking. and then followed by a couple of the Asian languages. So we have Chinese, Vietnamese, Korean, and Tagalog, Russian, and then some of the East African languages as being kind of most commonly spoken among this population within our state. And as is the case with the data that we have about racial and ethnic minorities, we also see that for those with limited English proficiency, there are higher rates of high intense end-of-life care. For example, these patients are more likely to receive mechanical ventilation in the ICU setting, to have restraints used. They're less likely to change code status from full code to DNR. They're less likely to receive a comfort measures order set, and it takes longer to transition to comfort care. And again, as we see with these other groups, they're less likely to have an advance directive. Okay, so with all of that as background, I'm now going to shift gears a little bit to talking about shared decision making. I want to start off with giving some frameworks to think about that, and then spend the bulk of my time talking about this intersection of health equity and shared decision making. So in this graphic, you can see one version of kind of the spectrum of decision making, where we go from the paternalistic approach, right? The approach that was really used most frequently in the past, where the clinician is presenting information, making a recommendation, frankly, making the decision. I think that this version, where it's showing kind of information and recommendations, can kind of be thought of as maybe a milder version of the paternalistic practice as it's used today. More commonly, clinicians are using informed medical decision making. And in this case, that sounds really good, right? Informed medical decision making. But in this case, the focus here is on they're just providing information in this one-way direction. And I think a lot of people think about this as shared decision-making in terms of, oh, as a clinician, I'm giving information to the patient, that's my contribution, and now the patient and their family possibly will make a decision. That's their contribution. And so maybe it feels kind of like it's shared because you're each doing something. But it's not. When we talk about shared decision-making, we're really talking about this collaborative process that is happening. So yes, the clinician is providing information, eliciting the patient's values and goals, and that is kind of feeding into a possible recommendation and really a discussion around how do the patient's values and goals in the context of what's going on clinically translate into specific preferences or decisions. And so if we break down this shared decision-making process a little bit more, this is a three factor decision-making model, struggling with the word there, from Elwin and colleagues, that highlights team talk, option talk, and decision talk. So in team talk, the idea here is that you're establishing that as the clinician and the patient and family, we're going to work together to make this decision. That includes describing choices, offering support, and asking about goals. And so they give the example of the statement, let's work as a team to make a decision that suits you best. That leads into option talk, where you're actually talking about the pros and cons of different options. So here, let's compare the possible options. And then that gets to decision talk, where you're actually then making the decision. You're getting to informed preferences and then making that preference-based decision. So in this case, they're illustrating that with a tell me what matters most to you for the decision, right? The part that's really the mainstay of palliative care, where we're eliciting people's values and goals. And I would say that, as we think about shared decision-making, part of the reason that this is so critical in the context of serious illness is because we are generally dealing with highly preference-sensitive decisions. right? So it's critical to understand the patient and family's values and goals in order to ensure that the decisions that are made are going to help facilitate goal concordant care. And so if we break this concept, which they also are kind of highlighting in the center there, that all of these steps require a combination of active listening and deliberation. So breaking down the deliberation piece, I think this is what is so challenging and rewarding about when we think about shared decision making in the context of palliative care, is how do you actually walk people through this process, right? Where you are talking about the different options, you're providing education to the patient and family about those options, but here's the key component of this process. How do you help people construct their preferences and translate those preferences into decisions? And so, you know, in this graphic, they're highlighting that for that whole process, some of the key context includes the emotional states of participants, their resources, constraints, and capacities, the range and accessibility of alternatives, and social norms that shape the construction of preferences. So this now is going to get us into kind of the heart of this talk about how did those things interface when we're thinking about equity. And so I would argue that as we think about shared decision making, in this paradigm, it's really attracting and benefiting those who are educated, empowered, and able to advocate, right? These are people who are able to utilize the skills to get the information that they need and to advocate for their needs. And so there is a real risk here of how, when kind of not employed properly, shared decision making can actually marginalize patients who are already disadvantaged and excluded. And so that gets us to this question of, okay, so shared decision making is an important way to ensure that people's values and goals are incorporated into the decisions that are made. But if it requires all of these things, then, you know, how does it impact health equity? So in thinking about some of the key factors that contribute to health inequities, again, as we think particularly about the for patients with serious illness, Kilborn, and I'll use this as a framework for evaluating healthcare disparities in general, and so I've adapted this a little bit. There are patient and family factors, and I'm going to go through these in a little bit more detail on the next slide. The clinical encounter, provider factors, healthcare system factors, and then really, if we were thinking most broadly, we would also be thinking about community factors, which I'm not going to really emphasize. So then in thinking about patient and family factors, there are two pieces here, right? So one is recognizing the way in which race, ethnicity, culture, familial context influence people's preferences for engaging in shared decision making. And then there is how those factors, and in particular, I would say language and literacy, affect shared decision-making behaviors. In other words, affect the ability of people to actually engage in shared decision-making for behaviors, you know, thinking about things like being able to ask questions, being able to initiate parts of the conversation. And so similarly, in terms of provider factors, you have race, ethnicity, culture, and familial context. This is related to the patient and family. How those factors influence the provider's own preferences for engaging in shared decision-making and for affecting the provider's own behaviors in terms of facilitating that process. And those come together in terms of the patient-provider relationship. And so here's where mistrust, for example, cultural discordance, not using interpreters when you're seeing patients with limited English proficiency, provider bias, whether that's conscious or unconscious, can all affect the way in which people are able to engage in this shared decision-making process. So with that kind of framework and context, what does the literature say about how the effects of shared decision-making, interventions on health equity? So I'm going to talk about two systematic reviews, one that was focused on shared decision-making effects specifically on equity, and then the other that was focused on shared decision-making effects in the context of serious illness, but not specifically around equities, to try to get at kind of both pieces of this issue for the patient population that we see and take care of. So from this review, they looked at 19 studies defining a shared decision-making intervention as any intervention designed to increase patient engagement or facilitate shared decision-making. And so that included a range of interventions that used communication skills training, coaching for patients and providers, and used different formats, including video, paper, computer-based, et cetera. So that's how they define shared decision-making interventions. And then they were looking specifically at studies where they had at least 50% of participants from what they called a disadvantaged group, defining those as either those with poverty, low socioeconomic status, those from an ethnic minority, and those with low education or limited health literacy. So that's the one study. The other study, and then I'll show kind of results in parallel. Then the other study that focused on shared decision-making intervention in the context of serious illness looked at 38 studies, 17 of which were RCTs, 21 were pilot or pre-post trials. They defined shared decision-making interventions as those that aimed at improving treatment decision-making. And there were kind of two categories then, those that utilized advanced care planning, so we're talking about future decisions, and those that were focused on current decisions. They also required these to be interventions that were really targeted or aimed at the patient or caregiver without clinician support. And so I think that's important to mention. So they excluded interventions that required communication skills training for clinicians or extensive patient coaching. And then they also included multiple formats, including print, video, web-based. And the patient population, or the kind of serious illness part of this, was that patients had to be 18 years of age or older. So this is focusing on the adult population. And they had to have either an advanced stage or life-limiting illness. Okay, so looking at some of the study effects then on patient knowledge. So this is from the first systematic review, the one that is focused on equity. And you can see here that in the several studies that they looked at, you do indeed see improvement in terms of patient knowledge. This is showing it as a binary outcome. They also looked at it as a continuous outcome. And then below, you can see the effects in terms of participation in the decision-making process. And in terms of some of the more kind of detailed findings in this area from the shared decision-making and health equity paper, they had 3 studies that showed that the difference in knowledge levels post-intervention disappeared for disadvantaged groups when the intervention was adapted for low literacy. Whereas in 2 studies, low literacy levels actually hindered participant understanding of intervention content. So I'm going to come back to this point a little later, but the importance of developing and ensuring that the content of these interventions is appropriate for those with limited health literacy. For the shared decision-making and serious illness review, they looked at 4 different ACP tools that were tested in 6 RCTs and found that 3 of the 4 tools did indeed improve patient knowledge. 10 of the 11 RCTs that were looking at current decision-making also improved patient knowledge. So again, you definitely see a trend here towards this improvement in the context of shared decision-making interventions. And I'll mention that one of those ACP tools, at least, which is the PREPARE intervention, has been designed with low literacy and kind of diverse populations in mind, not so much for the rest of those interventions. And then some of the other outcomes that they looked at in these systematic reviews were, what about effects on decisional conflict and self-efficacy? So you can definitely see, as you look at this plot, that the findings are not as pronounced as what we saw with patient knowledge, which was, I think, really the area where shared decision-making interventions made the most progress. As we look again at some of the individual studies in the context of those interventions that were tested in disadvantaged populations, you see that uncertainty was higher among low literacy participants pre-intervention, but that those disparities disappeared post-intervention, right? So the interventions were able to decrease the uncertainty around decision-making for those with low literacy. And then they found that there were some differences in terms of the format of the intervention, with low literacy participants then seeing lower decisional conflict with this kind of entertainment version rather than this written booklet. And in looking at the data around shared decision-making and serious illness, we also find multiple studies that were able to show decreased decisional conflict with these interventions. And then there were mixed results on actual decision-making, with many of these tools not actually changing the ultimate preferences that were made despite increasing patient knowledge. Similarly, mixed results on the increase in documentation of preferences, as well as affecting communication with providers about those preferences, with the strongest kind of evidence coming from, strongest evidence for, again, Rebecca Sidori's work with the PREPARE intervention, and then Angelo Volandi's work around these videos that have been developed to support decision-making in the context of dementia and then other serious illnesses. Okay, so thinking then about that literature where we see that depending on the content, you can see benefit for vulnerable populations through the use of shared decision-making interventions. What are some strategies then to really support this process? And I want to come back to the model that I shared earlier about shared decision-making to talk about how some of these factors contribute to some of these steps. And I would say that this is simplified because the reality is, of course, that trust affects the entire process. And the same argument can be made for some of these other factors. But so again, it's a little simplified. But as you think about team talk, for example, this idea of establishing that, okay, let's work as a team to make a decision that suits you best, I think that part really highlights the critical aspect of trust. And so in working with racial and ethnic minority populations, for example, it's critical to be able to establish that trust before you can really accomplish this first step in the process. In the same way, in terms of step 2, that option talk piece, thinking about language and literacy. How can people really understand these options that are being presented if that content isn't given in a way that people with limited health literacy can understand?
And of course, for those with limited English proficiency, if you're not using an interpreter and ensuring that information is being communicated correctly, there's no way that these patient populations can actually take away the understanding that they need to from this part of the process. And then when it comes to the eliciting values and goals and thinking about how that translates into a decision, really that collaborative deliberation process that's highlighted on the right, understanding the cultural context, the familial context of the patient population is critical to addressing that part about how those norms shape the construction of preferences, as well as how those preferences actually translate in terms of viable decisions or options. There, I'm thinking about things like hospice. So as we think about how to actually implement this in a clinical setting, how do we ensure that we can address issues around mistrust, around literacy, thinking about kind of the cultural context? There are a couple of strategies. And so I think this is so much at the heart of palliative care in general that it's a nice intersection there. And I would say that in palliative care, I think we are kind of best equipped to be doing a good job addressing these equity issues because of the focus on communication skills, active listening, eliciting people's values and goals. So it's like we're kind of at the precipice of actually effectively using shared decision-making to facilitate health and healthcare equity. So really simplifying the approaches to values clarification. Again, we're thinking about, the low literacy populations, but frankly, for everyone, really it's about what matters to you. Something like no one decision is right for everyone as you think about your options, what's important to you. So I think, really trying to simplify that to something that is easy for people to understand, regardless of kind of where they're coming from or their own backgrounds. And then as we think about the barriers to participating in shared decision-making, being very intentional about thinking about, are we addressing this person's ability to comprehend the information that's presented? Again, thinking about, the literacy level, the language interpretation piece of it. Using the communication skills training, I would say that this is like the core of the, fellowship in palliative medicine, is to develop these communication skills to extract and discuss information with others within the clinical context of what's going on. Thinking about the cognitive and social skills that people need to evaluate, interpret, and make informed decisions. And, I think that cognitive piece is especially challenging as we think about the population of patients with dementia. And so again, a place where we need to be thoughtful about how we can actually include people in a process that facilitates shared decision-making. And I think, back to that point about kind of understanding what's important to people, I think it's a key place where it's important to understand the root causes of those patient preferences, right? To distinguish between beliefs that are rooted in cultural traditions, for example, versus those beliefs that are stemming from misinformation, misconceptions, mistrust. And so that's an important piece, again, as we think about what is the role of patient preferences in driving inequities in care. It's critical that we understand that piece, right? What is actually about miscommunication or mistrust? Those things we can intervene upon and do something about. So here are some kind of concrete recommendations. Some of this work, some of these recommendations really come from the decision aid literature, but I think they're also relevant in terms of clinical practice and thinking about clinical encounters. In general, focusing on one or two main messages when you're communicating information, presenting essential information by itself or presenting it first, using analogies that are familiar and culturally appropriate. Here's a place where we need to develop materials in palliative care that are more culturally appropriate for different populations. Explaining numerical information in a way that's meaningful to the patient and families. And I have some more ideas about numbers on the next slide. Adding videos to verbal narratives. Again, I think in terms of developing shared decision-making interventions, that can be especially helpful. In terms of text, so now we're talking about written communication, using short sentences, using a conversational style. Limiting medical jargon, I think that's critical. Avoiding ambiguous words, using familiar words and using them consistently. And then avoiding symbols and question marks. And in terms of numerical information, to really kind of drill this down a little bit further, using pictographs rather than text. Presenting information so that the higher number is better. Also presenting information with the same denominator. Using natural frequencies rather than relative risks. And then finally using words like half or 1/3 when possible are easier to understand. And in terms of oral communication, stating your key point first and or last. Using a normal speaking rate, I thought this was really interesting. Speaking slowly makes patients focus on each word instead of the overall message. And I can definitely think of many, many times where and I've heard others, kind of slowing down the rate of their speech, right? When they're talking with someone, particularly in a cross-cultural encounter or someone in that setting. Avoiding jargon again. Being culturally respectful. Again, I think one could give actually a whole talk about how do you actually do that. Focusing on actions. And then one thing that I think is really helpful is to confirm understanding. And so employing things like teach back methods where you're really deliberate about ensuring that whatever information you have communicated has been received. And so having people say back to you what they're taking away from what you said. I also do find that to be especially effective when working with interpreters and with patients with LEP to again ensure that what you said made it through the interpreter and was understood by the patients in the way that you had desired. So I think that's a really effective method to use. So in terms of some of the key points that I want people to take away from this talk. First is that shared decision-making does indeed have the potential to improve health equity. But we need to recognize and understand the role of patient and family preferences, which stem from cultural and structural factors, as well as some of these other kind of structural and social determinants of health and how those factor into the process. And so it's important to remember that shared decision-making interventions could cause adverse outcomes for vulnerable populations if they're not tailored to low literacy levels, if they're not, culturally appropriate, and if they don't kind of also deal with these issues around establishing trust to facilitate this process and to think about how do you empower people, give them the self-efficacy to engage in the shared decision-making process, and of course the knowledge to understand what people are talking about, what the different options are. So on that note, I will show you a QR code for the evaluation, and I'm happy to take any questions.
Rashmi, Wayne here. That was absolutely terrific, but we shouldn't finish the hour without you having an opportunity to talk explicitly about your new grant, NIH grant. We have a bunch of current fellows, future fellows, recently former fellows on the Zoom this morning who may want to glom onto you, grab your coattails and either receive mentorship or help you with your grant goals. So could you spend a minute just talking about your award?
Yeah, I'm happy to. Thank you so much, Wayne. I appreciate the opportunity to talk about that. So I do indeed have a new R01 study that we're just kind of getting off the ground that's focused on identifying barriers to palliative care for older adults with dementia who have limited English proficiency. And this grant is focusing specifically on Latinx, Chinese, and Vietnamese populations. Those are both some of the larger populations within our UW Medicine and kind of greater Seattle community, as well as some of the populations that have the highest rates of limited English proficiency. And so this study is a mixed method study where we'll use EHR data to actually detect and examine in which palliative care domains some of these inequities exist. And then doing qualitative interviews with patients, family members, interpreters, clinicians to understand some of the barriers to palliative care at these multiple levels. So again, thinking about patient level barriers, provider level, the clinical interaction, the healthcare system. And then in the third aim, actually doing interviews with community-based organizations, with leaders of community-based organizations that serve these communities to kind of understand what are some of the barriers from that side in terms of thinking about how do we then develop a multi-level intervention to really help improve palliative care access and quality for these populations. So that's the focus of the grant and kind of the populations. And I would also say that I think in thinking about those with dementia, there's a real need to understand the way in which both culture and language affect, stigma around dementia, affect caregiving needs, caregiving burden, as well as caregiver resiliency. And so, for this population where the older adults also may not be able to express their preferences as they go through the course of their disease, how do you deal with all of those issues in a way that provides the support that the family needs and ensure that people are receiving care that's in line with what's important to them. So that's about that study, which I'm super excited about, and I'm more than happy to talk with folks who might be interested in this work.
Thanks, Rashmi. There are a number of questions in the chat. I wonder if I could read some to you. We'll see how many we can get to the time we have left. Amy Trowbridge says this is extraordinary, and she's curious what thoughts you have in navigating preference-sensitive decisions with patients for whom culturally they may be more accustomed to or might prefer deference to the clinician.
That's interesting. Should I just advance this slide that was actually kind of related to that a little bit? I think this is a really important point. The ice cream picture that I maybe just showed you now was a slide that I was going to talk about if I had more time to kind of illustrate this idea that, yes, we're talking about shared decision-making, but the reality is that there is a spectrum of decision-making preferences, and that a lot of people are coming from cultures that are much more that are less individualistic and more family-centered, both in their approach to communication as well as to their approach to decision-making. And so it's critical in terms of thinking about that first piece, people's preferences to engage in the process. And I think there's a nice paper from 2018 that talked about kind of cultural issues in palliative care. And one of the pieces that they talk about in that paper is really framing or thinking about the clinician's role in palliative care as not replacing the family, but as supporting or, kind of as a support to the family. And I think that framing is critical in cross-cultural communications. And so I think it is really important to understand what is the individual's patient's preference in terms of decision-making role, and to then align the decision-making process with those preferences. And if people's preferences are for their family members to be driving that decision-making process, then I think it's imperative that we honor that and then affect the way in which we engage in this process accordingly. So I think that's a really important point and kind of a first step.
Great, thanks. There's another question here from Gwen Bernacki. She asks, are shared decisions only shared between patient, family, and provider? How do we incorporate others influential to the decision-making process? And what if there's disagreement about whether the other party should influence the decision? And then I see examples of other parties. She has one example where there's a deceased DPOA, or another example where there are other providers caring for the patient, or what is the standard of care outside the provider's specialty?
Yeah, I mean, again, I think from the clinician point of view, thinking about that second piece, option talk. So if there are other providers whose expertise is critical to being able to talk about the different treatment options and the pros and cons, then I think it's a critical piece to involve those people. When you asked the question, I was actually thinking about others from the patient and family side, for example, religious advisors or spiritual, for people for whom religious and spiritual beliefs might be really important. So there may be other people from the patient and family sphere that are important to this discussion as well. And I think looking to the patient to kind of drive that piece of things, who are the important people in your kind of world as you think about these medical decisions, and then incorporating those people into the decision-making process. So I think there's actually a space for us to do that, both in terms of which clinicians need to be part of the process, which other interdisciplinary members of our clinical teams, as well as from the patient and family side, who does the patient and family see as being important to that decision. And I think in terms of navigating conflict, that's always a challenging thing to do. I think it's understanding what is driving different people's preferences and perspective, and then trying to look for common ground. At the end of the day, it's about the patient. Their voice should really be driving this process. And so if there's discord between others, it's listening to that, but trying to kind of reorient that at the end of the day, this is about the patient, and creating that trust to be able to establish, kind of shared goals going forward.
Thanks. I want to be respectful of time because we're at the 9 o'clock hour, but Rashmi, there are a couple other questions in the chat. I don't know how long we can stay on this line, if you might just be able to briefly answer or take note of who's asking.
Yeah.
But I think given it's the 9 o'clock hour, we should probably wrap up the formal part of this presentation. And thanks so much for sharing all this outstanding work.
Thank you, everyone. And I'm always happy to chat more about these things. So also feel free to reach out separately.
Well, no, somebody had requested your email and Randy put it in the chat. So anyone who's looking to further the conversation has access to her email. I'll put her email one more time.
So I'm going to move our fellowship applicants. You all have a shared break room where you will go in and out throughout the day. You'll have time to just communicate and get to know one another. I'm going to put you there for just a few moments until we can get Dr. Hirano back on the line, and then you all will have your program overview. Thank you, everyone, for joining. Take care. There's Annie. Now I see you. It's like I've got to put him in a break room. Oh, wait. Did Liz not go to the break room? Wait, what's happening? Oh, I didn't open. I'm usually so great at this. Today I'm having a flop day. Okay, let me assign you to the overview, then I'll move the candidates, Annie.
No worries.
Nitra, do I just stay around or I can